Good morning. Let's start chapter 16 about respiratory system. Let's begin this discussion with the anatomy of the respiratory system. You know that air is going to come from the nose, is going to get to the pharynx, and then it's going to come to the larynx, this part. It's going to come to trachea. Trachea is going to divide to two bronchus. Each bronchus is going to go to one lung, and then this bronchus is going to branch off more and more, just like this. This bronchus is going to change to a bunch of branches and finally is going to create bronchiole. And bronchiole is going to branch off further, create terminal bronchiole. And then after terminal bronchiole, we have respiratory bronchiole. And respiratory bronchiole is going to end up to these tiny sacs we call alveolus. From the trachea all the way to the terminal bronchiole is called conducting zone. Because what happens, air is going to come through these branches until it gets here, and there is no exchange between the air and blood. After terminal bronchiole, where we call respiratory bronchiole, is where the exchange happens. That's what we call respiratory bronchiole. After terminal bronchiole, respiration happens, exchange of gas happens. Of course, the most effective place to exchange gas would be alveolar sac, but yes, respiratory bronchiole can exchange gas as well. So therefore, as I mentioned, from trachea all the way to terminal bronchiole is called conducting zone, and after terminal bronchiole is called respiratory zone. Respiratory zone because exchange of gas takes place right there. If you look at one alveolus, you can see the wall of alveolus is composed of a cell. This cell and this cell is called type 1 alveolar cell. We have another cell in the wall of alveolus, it's called type 2 alveolar cell. Type 1 create the wall of alveolus and also is going to release an enzyme it's called ACE. Do you remember ACE? Angiotensin converting enzyme. We mentioned this one when we were talking about the renin-angiotensin aldosterone system. Type 2 alveolar cell produces surfactant. Surfactant that is released from type 2 is a phospholipid. Surfactant would be very important for us in your respiratory system. Let's say this one is one alveolus, this one. Of course, I drew it pretty big, but it's a microscopic structure. It's a very tiny structure that you can see it only with microscope. Inside this alveolus, you have small amount of water. Very, very, very tiny amount of water. When water are next to each other, they're going to attract each other by hydrogen bond. Hydrogen bond is going to bring the molecule of oxygen close to each other. Have you ever washed a plastic bag? When you wash a plastic bag, the wall of this plastic bag is going to attach to each other. It's going to be hard for you to open it because molecule water is going to attract to each other by hydrogen bond and it's going to prevent this plastic bag to open. If you wait until it's going to get dry, then you can see easily you can open it because the water is gone and hydrogen bond is not there anymore. Imagine that you are dealing with an alveolus and inside this tiny alveolus we have a small amount of water and as a result the wall of alveolus is going to collapse. So every time you are trying to open it you have to overcome this hydrogen bond before you can breathe in. To break this hydrogen bond, to break the bond between molecule of water, we have something that's called surfactant. Surfactant is phospholipid and it's going to come between the molecule of water and breaks up this bond. As a result, alveolus is not going to collapse anymore. It's going to stay open. Attraction between the molecule of water creates something that's called surface tension. Surface tension is a tension created by this hydrogen bond. And phospholipid is going to go and break down this surface tension. As a result, it's going to decrease the chance of collapsing your alveoli. Also, I need to remind you about the structure of the lung. Your lung is surrounded by a sheet, this red one. This membrane that surrounds the lung is called pleural. It's one sheet, but it's going to fold on its own. So as a result, we have now two layers. One layer here is called visceral, and one layer outside is called parietal. Visceral layer is stuck to the wall of lung. The parietal is outside. Between these two layers, we have a small space. It's called pleural space. And inside this space, we have a small, tiny amount of fluid also. It's called pleural fluid. If this is your lung, the visceral is right on top of the lung and is attached to the lung. It's stuck to the lung. You cannot separate them. This is going to fold back and it's going to create what? Parietal. This blue one is parietal. Parietal is stuck to the chest wall. So this black one I'm drawing is a chest wall. So why this one is important? Because as your chest wall moves, your parietal layer is going to move, because parietal is stuck to the chest wall. As your chest wall is going to expand, your parietal is going to expand, and as a result, this space here is going to expand. That's very important for us to remember. So visceral layer is stuck to the lung, parietal layer is stuck to the chest wall. At the bottom of the lung, we have diaphragm. Here's a diaphragm, right? Yes? Your lung is sitting on the diaphragm. The parietal also is attached to the diaphragm. So the parietal is attached to the chest wall. So if the chest wall expands from the side, parietal is going to be pulled out. And parietal also attached to the diaphragm at the bottom and is going to be pulled down also. So that's a very important point we're going to use later. Now let's start with physiology. The first thing I want to know about the physiology of respiration is about pressure. We are dealing with different type of pressure and each one has a different name. It can be slightly confusing because we are dealing with different type of pressure. The first pressure that probably you need to know is called lung pressure, or it's called atmospheric pressure. By definition, we say that pressure is zero, although it's not zero. The pressure in this room is 760 millimeters of mercury. But by convention, we say, let's assume it's zero, because it's easier to calculate, it's easier to deal with. But in reality, the pressure in this room is what? 760 millimeters of mercury, or 1 atmospheric pressure. There's another pressure, it's called intrapulmonary pressure. More commonly, it's called alveolar pressure. Sometimes it's called respiratory pressure. This is a pressure inside the alveolus. This is the outside. The pressure here is around 760, but we consider as zero. If you open your mouth, the pressure outside your lung and the inside your lung will be equal. So therefore, if that is zero, here must be zero also. So alveolar pressure at the normal situation also is zero. If I open my mouth, the pressure outside in this room and pressure inside my lung will become equal. There is no need for air to go in and out. So therefore, the pressure inside the lung also will be considered zero. The next pressure that you need to know is intrapleural pressure. It's a pressure between the visceral and parietal pleura. Let me show you. In this picture, this line here would be parietal layer. This one would be visceral layer. This space here is intrapleural space. And the pressure here is called intrapleural pressure. And the name for pressure here is called intrathoracic pressure. This darker one would be chest wall. This darker wall would be diaphragm. The pressure here is 5 points less than pressure outside. Remember, the pressure outside is 760. So therefore, here must be 755. But instead of saying 760 and 755, we say the pressure is zero and the pressure here is minus 5. Again, it's not less than zero, but if this one is zero, this one is 5 points less. That's why we say it is more negative compared to outside or inside the lung. And the next pressure that I want you to know, which is very important, is called transpulmonary pressure, or it's called transmural pressure. Transpulmonary pressure is a difference between intrapulmonary pressure and intrapleural pressure. That is the pressure here. The difference between pressure here, which is 760 in reality, and the pressure here, 755 in reality, so it's going to be minus 5. So this pressure, minus 5, is the difference between pressure here and pressure here is called transpulmonary pressure or transmural pressure. Because the pressure inside this pleura is negative compared to this one, it's going to create a small vacuum. And remember, a vacuum is going to pull things toward itself. When you do vacuum cleaner, how come it's going to clean? Because inside the machine, you're going to create a vacuum, and vacuum is going to pull things toward itself. In the Hollywood movie, when a bomb explodes inside the airplane, everything is going to get pulled out inside the space. Why? Because space has vacuum, and as soon as there is an opening in the wall of the airplane, everything is going to be sucked out. The point here is this. This negative pressure is going to pull this visceral layer out because it's a vacuum compared to here. And remember, the visceral layer is stuck to the lung. So if I pull this one out, I'm going to pull the lung out. As a result, lung is going to expand. So this negative pressure would be super important for us because it's going to keep my lung and airways open. Another thing I have to mention as an introduction of this physiology is when you stand up, of course there's a gravity. Because of that, blood flow is the best at the bottom of the lung, not at the top of the lung. If air comes to the top of the lung, there's not enough blood to exchange these gases. Let's say this is one alveolus, and when the air comes in, when the oxygen comes in, this oxygen needs to be exchanged. That means surrounding the alveolus, I have to have blood. I have to have blood here, so then oxygen can get inside the blood. If there is no blood here, when the oxygen comes, where this oxygen is going to go? So I have to have a good perfusion. It's called perfusion. When the oxygen comes, oxygen can get inside the blood. So now think about it. If the blood perfusion in the apex of the lung here is not very good, when the air comes to the alveolus here in this area, it's not going to exchange. So therefore, air prefers to come to the alveoli at the bottom of the lung because bottom of the lung has better perfusion, has better blood supply. As a result, oxygen can get inside the blood. However, when you lay down, then the gravity is going to be applied to every part of your lung. As a result, this issue will be removed. The next topic of physiology, which is really important, is called dead space. You remember I told you when the air comes inside the trachea, air is going to go inside these branches, bronchus, and then it's going to come to the bronchiole until we get to the terminal bronchiole. We said all this area is called conducting zone because air is going to go through without being exchanged. Every time you breathe in, we call tidal volume, and that's around 500 ml. When you bring 500 ml of air inside your respiratory system, this air is going to fill this space also. Out of 500 ml that you breathe, 150 is going to stay inside the conducting zone and doesn't do anything. 350 is going to get inside the alveolus and now we can exchange. So this 150 really is a dead space. We call it anatomical dead space because anatomically this area is not able to exchange air. Some alveoli, they don't have a good blood supply surrounding it. So although air is going to come inside the alveoli, but if you don't have a good supply of blood surrounding the alveolus, air is not going to get exchanged. That is also useless. We call that one a functional or alveolar dead space. A functional dead space or alveolar dead space is an alveolus that has the air but doesn't have perfusion surrounding the alveolus, so therefore air cannot get inside the blood. If you add anatomical dead space and functional dead space together, we call it a physiologic dead space. We showed it VD. Or it's called a total dead space. In a normal person, we expect that this functional dead space be close to zero, although it's not zero, but we expect that to be close to zero. In many diseases, this functional dead space may increase. As a result, your physiologic dead space is going to increase. To measure physiologic dead space, we're going to use this formula. Let's say this is one alveolus, and this is the whole thing is lung, right? The pressure of CO2 inside the alveolus, P CO2, it shows as P capital CO2. This A means alveolus. The pressure of CO2 inside the artery shows as a PA CO2 with lowercase a. So when you see uppercase a, we are talking about the alveolus. When you see lowercase a, we are talking about lung. When someone breathes, the CO2 is going to come inside the alveolus, and then you're going to expire this air. If the dead space was zero, then the amount of CO2 that you expire here would be the same amount of CO2 that you expire outside. So if I get your expired PE CO2, if there is no dead space, must be equal to PA CO2. Is that correct? If you have a dead space, this CO2 is going to get diluted inside the dead space. The pressure is going to drop. In other words, the more dead space you have, the lower PE CO2 would be compared to PA CO2. In other words, the more dead space you have, PaCO2 would be higher and PeCO2 would be lower because you're diluting the CO2 inside the dead space. If I can figure out this one and this one, then I can figure out how much dead space you have, because the difference between these two must be the dead space. This formula is going to use this idea to find out how much dead space you have. However, here's a problem. I can measure PeCO2, I can measure the amount of CO2 that you have in your expired air. But how can I measure PaCO2, the CO2 we have here? That's going to be very difficult. I have to put an instrument inside the alveolus to measure how much CO2 you have. So how are we going to overcome this problem? Well, the answer is, this CO2 that comes here, where is it coming from? Do you remember that in your heart, you have pulmonary artery? That pulmonary artery is going to bring blood to the lung. So the CO2 inside this artery is called PaCO2, should be equal to the CO2 that you have inside the alveolus. So that these two must be equal. So if I measure the CO2 that you have inside the pulmonary artery, then that is going to be equal to the amount of CO2 that you have inside the alveolus, because after all, this CO2 comes from the CO2 inside the pulmonary artery. So it's not very difficult to get that. Then using this formula, we can find out your dead space. Now think about it. I have your tidal volume. I can figure out how much air you're breathing in and out. I can measure the CO2 inside the artery. I can measure CO2 inside expired air divided by CO2 inside the artery. If you use this formula, it's going to give you your physiologic dead space. After we learn about dead space, let's talk about ventilation. We have something that's called total ventilation. Every time you breathe in and out, we said your tidal volume is 500 ml. How many times do you breathe? Well, your respiratory rate, this shows as F, is somewhere around 12 to 20 times. So let's say you breathe 500 ml every time, and let's say you breathe 12 times a minute. That is going to become 6,000 ml of air that you move in and out in 1 minute. That is called your total ventilation. Total ventilation is a total amount of air that you move in and out in 1 minute. I just mentioned a few minutes ago that out of this 500, 150 is going to be dead, is not going to exchange. So what is going to get to your alveolus is not really 500, it's 350. So therefore, alveolar ventilation is 500 minus 150, which is dead space, times 12. So alveolar ventilation is less than total ventilation because 150 ml every time you breathe is wasted. So therefore, it's going to be 300 times 12, and that is equal to 4,200 ml. So why this one is important? Why is it important to understand the difference between total ventilation versus alveolar ventilation? This is total ventilation. This is alveolar ventilation. Let's consider person A versus person B. Person A is going to breathe 600 ml air every time, tidal volume, and he's going to breathe 10 times a minute. Person B is going to breathe 300 ml every time and breathe 20 times a minute. Both of them, they have a total ventilation of 6,000 because 600 times 10 is 6,000, 300 times 20 is 6,000. But which of these two is breathing more efficiently, breathing more effectively? Well, the answer is person A is breathing 600 ml, but 150 ml is dead and breathing 10 times a minute. So that is going to be 450 times 10. This guy is breathing 4,500 ml in and out of the alveolus. This person A. Person B, however, breathing 300 every time, and 150 is dead and breathing 20 times. That is going to be 150 times 20, and that is going to be 3,000. As you can see, person A is breathing much more effectively because in 1 minute he's exchanging 4,500 ml of air, but person B is only exchanging 3,000 ml of air. So the message you want to take home is this: you better breathe slowly but deeply than quickly but shallow. This type of breathing is not recommended. because majority of this air is being wasted as dead space. But if you breathe deep but slow, you're exchanging more air inside your alveolus. Before we move forward, I need to go through some terminology because we need this terminology in our discussion right now. The word eupnea is a normal quiet breathing, the way that you breathe and I'm breathing right now. That's eupnea. If you increase your breathing, if your breathing rate or depth of your breathing increases because of increasing metabolism, that's called hyperpnea. When you're on treadmill and you're running, you're going to start breathing fast and deep. That is called hyperpnea. The term hyperventilation, hypoventilation has nothing to do with the pattern of your breathing. Hyperventilation and hypoventilation depends on how much CO2 you have in your alveolus or inside your pulmonary artery. If I breathe to the point that my CO2 in the blood goes up, I am hypoventilating because I'm not breathing enough to exhaust the CO2. In hyperventilation, you're exhausting too much CO2. As a result, your CO2 in the blood goes down. A normal pressure of CO2 in the blood is 40 millimeters of mercury. If your PaCO2 in the blood goes down to 30 and 20, you're hyperventilating. If you're not breathing enough, that means you're accumulating CO2. That means the PaCO2 from 40 is going to change to 50 or 60, you're hypoventilating. Hyperventilation is going to decrease your PaCO2. Hypoventilation is going to increase your PaCO2. The medical terminology for panting is tachypnea, and if you have abnormal pattern of breathing because of some pathology, it's called dyspnea, and if you don't breathe at all, it's called apnea. Knowing this one, let's talk about alveolar ventilation equation. Alveolar ventilation equation, you will see, is a mainstay, is a very important principle of respiratory physiology. This equation says that when your alveolar ventilation increases, your PCO2 inside the alveolus is going to decrease. Now think about it. We talked about alveolar ventilation a few minutes ago. If I increase my alveolar ventilation, that means I'm going to speed up the exchange of air in and out of my alveolus. If I speed up this exchange of air, that means I'm exhausting more CO2. That means CO2 inside the alveolus goes down. That means I'm expiring more of CO2 inside the air. As a result, my PaCO2 also is going to go down because, again, this CO2 comes from the blood. So basically, alveolar ventilation equation says that there is an inverse relationship between alveolar ventilation and PaCO2. The more you ventilate, the lower PaCO2 will be. Look at this one. VA is alveolar ventilation is equal to VCO2, the amount of CO2 that you produce due to metabolism, times a constant number is called K, divided by the pressure of CO2 inside the alveolus. This is a constant number, so we can ignore this one. And if I ignore this one, and I rearrange this formula, the PaCO2, the amount of CO2 that you have inside the alveolus, depends on how much CO2 you produce, and depends on your ventilation rate. In other words, if I forget about K, because again K is constant, then my PaCO2 depends on how much CO2 I'm producing, metabolic CO2 production, divided by alveolar ventilation. If my alveolar ventilation goes up, my PaCO2 is going to come down if my CO2 production stays constant. So right now, I'm producing CO2 in a normal amount. If I start ventilating faster and deeper, I'm exhausting CO2. The CO2 in my blood is going to go down. If I stop ventilating, if I stop breathing, then my PaCO2 in the alveolus and inside the blood is going to go up. To understand this one, let me ask you this question. If you are running on treadmill and you're breathing fast and deep, of course, are you hyperventilating? Now think about it. The answer is no. Why not? You are hyperpenic. You're breathing fast and deep, but you're not hyperventilating. Why not? Because, as you can see in this formula, yes, your ventilation is higher when you're on treadmill, but also you're producing more CO2. The numerator going up, the denominator going up, therefore the PaCO2 is going to stay constant. When you're on the treadmill, you are not hyperventilating because your CO2 in the blood stays constant. you're producing more CO2 also. You produce more CO2, you exhaust more CO2, therefore your PaCO2 is going to stay around 40. How can I figure out how much CO2 I'm producing? The answer is the CO2 that you produce is going to come inside the venous blood, yes or no? It's going to go to your vein. So if I get a sample of the blood from the vein and measure the CO2, I can get this numerator also. So therefore, instead of metabolic CO2 production, I can put PvCO2, the CO2 inside the vein. Can I measure my PaCO2? I mentioned a few minutes ago, yes, we can, by measuring the CO2 inside the pulmonary artery. And as a result, I can easily find out my alveolar ventilation. The relationship between alveolar ventilation and PaCO2 is not linear. In fact, it's a hyperbolic shape, just like this one. Here in this diagram, you can see alveolar ventilation. Here you can see the PaCO2 or PaCO2, which are the same. If your alveolar ventilation is around 5 liters, then your PaCO2 would be around 40 millimeters of mercury, which is normal amount. If you ventilate more, if you increase your ventilation, as you can see, your PaCO2 is going to drop from 40 to 30 and then 20. If you produce more CO2, if your CO2 inside the blood increase from 200, let's say, which is normal, to 400, then you have to ventilate more to keep this 40 in place. I have to ventilate more to exhaust more CO2. As a result, my PaCO2 is going to stay around 40 as well. So therefore, as you can see, when you produce more CO2, your curve is going to move to the right. Before we take a short break here, I want to talk about something you already should know, and that is, why is that when you hyperventilate, you're going to get dizzy? The main control of cerebral circulation, we said, is CO2. If the CO2 goes down, as a result, your vessel in the brain is going to go to constriction. And when the vessel in the brain goes to constriction, that means less blood is going to get to your brain. As a result, you're going to get dizzy. But why is that? The simple answer is, when the CO2 goes down, that means your pH is going to go up. You remember that CO2 is going to join water. We mentioned this one. It's going to create H2CO3. H2CO3 is going to break down to H and HCO3. And this guy is going to decrease your pH. If your CO2 goes down, that means you don't have enough H. That means your pH is going to go up, becomes alkaline. You should understand that alkalosis, when pH goes up, is going to cause vasoconstriction. So the main reason that when you hyperventilate, you're going to have constriction of the vessels is because of alkalosis. On the other hand, if you have acidosis, then your vessel is going to open up. But why alkalosis cause vasoconstriction anyway? When your blood becomes alkaline, calcium is going to attach more to the albumin. As a result, your free calcium, your ionized calcium in the blood is going to go down. And when the amount of ionized calcium in the blood goes down, then it's going to affect your nerve and muscle. Your muscle is going to go to contraction, your vessel is going to get constricted, and also your nerve starts getting agitated and is going to send a lot of impulse. As a result, this patient is going to feel tingling because neurons are agitated. If the CO2 stays low for a longer period of time, then the patient may go to tetany. Now, I have to make sure you understand this one because some of you probably right now is confused. Some of you right now thinking that, wait a minute, you said calcium is needed for muscle contraction. And now you're saying if the calcium goes down, your muscle is going to contract. How does it make any sense? Remember, for muscle contraction, we need calcium inside the cell. This calcium is inside the blood. If the blood calcium goes down, your muscle cell is going to go to contraction. That is different than calcium is inside the cell. This is cell. If the calcium inside the cell goes down, contraction is going to stop. We are talking about calcium inside the blood. If calcium inside the blood goes down, then the muscle is going to go to contraction. The mechanism is different than what you saw inside the cell. So don't confuse these two with each other. So let's take a short break here. We're going to come back with the rest of this recording.